Just to give a background, about 25% to 35% of adults in the West are affected by non-alcoholic fatty liver disease. The percentage in the GCC is not clear, but estimated over 30% of adult population suffer from fatty liver disease. I anticipate the numbers are even bigger, and there is a study done on diabetics in Bahrain from Health Center. 68% of them are affected by fatty liver disease based on ultrasound and clinical criteria. An estimated 33% of non-alcoholic fatty liver disease and Nash patients will progress to hepatic injury and inflammation with fibrosis. Hepatic decompensation and cirrhosis has been shown to develop over a mean period of 7.6 years in about 3% of population diagnosed with non-alcoholic fatty liver. Decompensation of Nash has a median survival of 2 years. So once the patient presents to you with end-stage liver disease, their survival is worse than that of heart failure. Hepatic steatosis is also an independent risk factor for development of hepatocellular carcinoma, and 7% of patients with non-alcoholic fatty liver-related cirrhosis will develop HCC over 10 years' time. This is now the commonest cause of hepatocellular carcinoma in the developed world as well as in the Middle East. Now, the natural history of non-alcoholic fatty liver said in the West, about 25% of population suffer with this, and non-alcoholic fatty liver will develop into NASH in about 10 to 30%, I would say a quarter of the cases. Out of those, 10 to 15% will progress to end-stage liver disease or liver transplantation or HCC. Meanwhile, during the period of NASH, many of them succumb to cardiac death. As you know, these metabolic disorders in the liver are a surrogate for severe metabolic disorder all over the body, and cardiovascular risk takes the life of these people even during the development of their NASH cirrhosis. Now, from healthy liver to fatty liver, there are several stages. First of them is insulin resistance and lipogenesis. So whatever sugar cannot be utilized in the body due to insulin resistance will enter the liver in the form of triglycerides. The liver will store the triglycerides, will make cholesterol, and will develop into type 2 diabetes because it cannot control the homeostasis of sugar. Eventually, this liver accumulation of fat will end up with inflammatory response because inflammatory cells will be attracted to eat up this fatty liver deposit. Inflammation is a civil war in the liver. It leads to destruction of the fat containing cells as well as the normal cells. Eventually, the architecture of the liver is affected, and the stellate cells from the bile ducts will end up attacking the liver cells and causing fibrosis. So in stage of inflammation, from site of inflammation or war, destruction comes, the scaffold of the liver, the stellate cell will build fibrosis. So eventually it will end up with cirrhosis. Fibrosis can progress from mild fibrosis in stage 1 to stage 2 to almost a nodular pattern crossing the liver between the central vein and the portal triad, and eventually will form nodules, which is cirrhosis. Once nodules at stage 4 develop, portal hypertension will set in, as well as liver failure and ascites. Liver biopsy remains the gold standard of staging this fibrosis, but it is invasive, it is expensive, it has a complication rate of 0.6 per 1,000 case, and is subject to sampling error because when you sample the liver, you're not going to sample all the areas of the liver. And fibrosis can occur in one area predominantly, leaving others with inflammation but no fibrosis. Liver biopsy is also impractical if you want to repeat a follow-up of a patient to see progress. So non-invasive methods have developed, and the one used in our hospital is called the pulse shear wave method. It's done routinely in our clinic as well as in the radiology department. There are other methods like fibroscan and MR elastography. The fibroscan has the deficiency of being so operator dependent, unlike the shear wave, which is non-operator dependent. MR elastography is thought to be even more diagnostic than shear wave. However, with the improvement in the shear wave technology, this is becoming highly correlating with MR elastography. And therefore, these tools are becoming effective and useful even in randomized trials when they test therapy of Nash. The stiffer the liver is, the faster is the pulse travel through the liver, and therefore a speed of 1 meter per second or less is considered to be normal. Anything above that is considered abnormal. So these are the modalities available. There is now a 2D shear wave, whereby a bigger area of the liver is sampled within a square, and you can take multiple readings within this area to assess different segments of the liver and see the shear wave in it. Point pulse shear wave is now considered routine. This one is even more advanced. So how accurate is shear wave in measuring liver fibrosis? The first studies that came in viral hepatitis, not in Nash, and published. The first biggest study was done by Frederick in 2012, and it published the correlation between liver biopsy and shear wave measurement. And as we go from no fibrosis below 1, at 1.8 meter per second, it is reported as showing fibrosis. The cutoff point is beginning of fibrosis at 1.5. How accurate is shear wave in detecting Nash, however? Is it accurate or not? We looked at our data here. How accurate is shear wave in predicting the liver fibrosis on a liver biopsy? So one of the things we looked at is anybody who was going to cholecystectomy or bariatric surgery who has Nash on our scan is advised to have a liver biopsy during the procedure. So we're not exposing them to unnecessary percutaneous liver biopsy, not exposing them to risk of a liver biopsy closed technique, but we're doing it during their surgery. And therefore, we did a shear wave measurement in fasting state the same week as the surgical procedure. The slides were submitted to the pathologist, who was not aware of the shear wave till reading was done. A total of 54 patients were included, predominantly females, 63% of them. The average age of these patients is about 50 years of age, and the mean weight was 110 kilos, BMI 39. So they were basically morbidly obese people. Diagnostic accuracy of shear wave score predicting liver fibrosis was assessed by the liver biopsy as the gold standard, and we plotted the correlation between the fibrosis score and the sensitivity of the technique of shear wave. So what we came up with is sensitivity of 83%, specificity of 80, and diagnostic accuracy of 81.4. The shear wave is drastically elevated to 2.8. It predicted severe fibrosis of F2 stage or more. A score below 1 was predictive of no fibrosis. This was submitted to DDW as an abstract, and the group here involved myself, Dr. Manzoor, Dr. Rajesh, and Dr. Mary Jane. We'll continue to accumulate more data on liver biopsies and shear wave correlation. This is the plot of the curve showing the correlation. So how do we approach a patient once we diagnose this patient has Nash? What do we do about it? Do we stay silent? Do we try to change the prognosis? All these patients diagnosed on Nash based on clinical history and shear wave criteria were followed up so we have data between 2016 to 2023, and we offered them treatment for obesity, as well as correcting their metabolic disorder and treating their hyperlipidemia, sugar, and so on. If they had cardiac issues, we also took care of it. If they had renal disorders, we took care of it. A total of 419 cases were detected, 392 cases were compensated, so they did not have symptoms of liver failure at time of detection, but 27 patients presented as liver decompensation and stage liver disease manifested by ascites, jaundice, encephalopathy, variceal bleeding, low albumin, coagulopathy, or hepatocellular carcinoma. So anybody who had these decompensation findings was treated as a liver failure and followed up as a liver failure. The aim of the study was to evaluate the clinical course, so what happens to them with time, and the effect of weight management, if it at all will change their prognosis. I encourage people to do ultrasound routinely, looking at the liver morphology and echogenicity and looking at the rest of the abdomen, because it's a very useful, cheap study, can be done at the bedside. It will give you a tremendous idea about what's happening to this patient. So ultrasound, first encounter of patient, is easy, it's bedside, a method to detect increased echogenicity of the liver, comparing it to the right kidney. A bright liver is a fatty liver till proven otherwise. Estimation of the size of the liver, both left and right lobe, is always listed in our files. And it is informative also in detecting decompensated liver, because you will see an irregular margin of the liver, you will see scalloping of the liver, you will see that the portal vein is dilated, indicating portal hypertension. We routinely measure the portal vein and portal flow to see if there is thrombosis. We look for spleen size as a measure of portal hypertension. We look for varices or collaterals. We look for hepatocellular carcinoma. It takes time in the first study to look for these cases, but also is very informative about the baseline of this patient and will allow you in follow-up to see if there is progress going in the right or the wrong direction. When advanced, I learned the lesson that when I see an obese patient with a normal echogenicity of the liver, it's a bad sign. That means he turned from fat to fibrosis. So echogenic liver is still fat. But when you see this echogenicity almost normalizing compared to the kidney, that's not a good sign. That is a sign that fibrosis has replaced fat. So as the inflammatory cells eat up the fat, they deposit, the stellate cells deposit fibrosis, which will bring the echogenicity to near normal. You should not be fooled by that. Newer modalities to estimate fat fraction are available in our hospital now, and both myself and Dr. Sana, we are collaborating on screening fat fraction in the liver to compare it to MRI fat fraction to see if we can detect excessive fat deposition in those people who have echogenic liver. How useful is fat fraction? It's very useful when you put the patient on a diet or a modality to reduce weight, because you can do repeated fat fraction and estimate, is the patient really losing this fat or not? So now it is a routine parameter in Nash studies in follow-up of drug therapy. And I will talk about drug therapy for Nash in a little while. So out of all our cases, majority were compensated at the time we detected them, but 6% presented with liver failure. Majority of our sample was females. Is Nash more common in females than males? Not really. In our area, it may be. Why? Because we have an epidemic of obesity and sedentary lifestyle among women. Many of them have multiple pregnancies and gain of weight with every pregnancy, which fails to come back to baseline. So these multipara women in their 60s now have presented a big problem to the public health with liver failure and Nash. I would love to see a screening of elderly population, I mean above age 60 in Bahrain, and see how many of them have increased abdominal girth and fatty liver. Among the decompensated, also the majority were females. And what we did for these people is, how do we approach their fatty liver? The first step is, of course, to inform the patient, you have fatty liver. Most people say, what is fatty liver? Fatty liver is a description of an animal who's like a fat sheep. That's how they tell me in Arabic. You're comparing me to a fat animal. I said, no. When you develop obesity in the center of the abdomen, you develop fatty liver, and fatty liver can be associated with lots of diseases. So educate your patient, tell them you have this condition. It's very silent clinically. Therefore, they will not come to you complaining. I will list the complaints they show up with, but they're not aware till you look for it. So inform them. Then we look at their demographics, the age, the gender, the weight, the height, the BMI, and most important, the abdominal girth at the iliac crest, because it's a very cheap, easy bedside measurement which will tell you this patient is at risk, and whether on diet this abdominal girth will come down correlates definitely with the liver. Every kilo they lose 1 centimeter from abdominal girth. That's a correlation which I found repeatedly. Patients with viral, alcoholic, or iron overload or autoimmune diseases were excluded from the sample. All these patients were advised to start a low-carb diet under supervision of dietitian, and they were offered to be followed up freely with the dietitian every 2 weeks for 1 year to see what happens to their weight progress. We also screened them for associated renal or cardiac diseases and addressed these issues, controlled their diabetes, managed their insulin. As they lose weight, their insulin requirement sometimes totally goes to zero, and we don't want them to go into hypoglycemia. We also adjusted their antilipemic therapy and adjusted their risk factors if they have cardiac or coronary disease. They were definitely screened and referred. Those with morbid obesity or those who failed to lose weight, if willing, will be referred to a bariatric surgeon. We refer them to bariatric surgeon now. As I can tell you, there is a huge resistance to bariatric surgery here, saying this surgery kills people. Yes, it can kill a few people, but it also can save a lot of people. If done by the proper surgeon, I tell my patient, if done by the proper surgeon under the proper circumstances, the surgery can be life-saving as well. Between 2020 and 2023, when GLP agonists became available and useful in this management, some patients were advised on GLP agonists, again, if they agreed or they could afford this therapy. All patients willing were started by the dietitian on the diet. They were followed up every 2 weeks. They were advised moderate exercise depending on their cardiac reserve. So we always screened for coronary disease before we tell them hit the treadmill or the gym. We don't want people dying in exercise. They were screened if their angina was not there or their arthritis allowed moderate exercise advised. Even chair exercises for those with arthritis were recommended. Clinical follow-up was scheduled by the physician after 6 weeks of onset of diet. Shear wave measurement was repeated at 20 and 52 weeks if the patient agreed and showed up for it. So these are the presenting symptoms. What the clinician should look for is the following. The first thing is when the patient walks into your clinic, look at their abdominal girth. You can grossly look at it. You will estimate central obesity or no central obesity, provided you're looking at the abdomen, not looking at their abaya from outside. Elevated liver enzymes will be present in about 61% of cases. So we will miss 40% of cases if we look only for liver enzymes, because they're not always elevated. Hyperlipidemia, hypertension, diabetes are present in almost 50% of cases. Other findings which they present with, like right upper quadrant pain. Interesting that about 43% of them will report to you to the clinic because of right upper quadrant dull pain. It's not a severe pain, it's an aching pain. They say when I lie down on the right side, it is tender, so I have to toss to the other side to relieve my pain. If you press on their liver, it is tender. It's not a severe pain that will knock the patient out, but it is there. Nausea, fatigue, foot pain, and all symptoms of liver disease in those minority who present with decompensation, like ascites and low platelets and varicose bleeding. So reality is different than what you wish to do in life. So you recommend a low carb diet, you give them free follow up, but among them, still on first encounter and after all the explanation you give and after all the discussion you have with the patient, still 41 patients refused a dietary consultation. Said, I'm not interested in eating without carbohydrates. I'm not interested in following a diet. I want to enjoy my life. I want to eat all the sugar I want. And if you take their history, these people live on sugar and carbohydrate. They avoid meat. They skip breakfast routinely. They eat massive amount of dates in our culture because dates is a fruit. It's not a sugar. They'll tell you this is natural. But date is a culprit in diabetes in our area. And it is something you should ask for by history. Because you ask them, do you eat sugar? No, I don't. How many dates do you eat? 10 a day. So among those who were instructed and given a booklet and given a phone call to follow up, only 228 were compliant to the diet, 70 were totally non-compliant to the diet, and 79 of them failed to even show up for measurement of weight or abdominal girth measurement after diet instruction. So those were referred to bariatric, 33 cases, diet alone 169, and we end up with 26 on Ozempic plus diet. So this is the shear wave distribution among our sample at baseline. Majority of cases are in F2, F3 fibrosis. In the decompensated cases, these are the findings: ascites, low platelets, gastric or esophageal varices, hepatic encephalopathy. So what happened to these decompensated cases? Those who survived and did not die with cardiovascular event, and about 8 died with cardiovascular event during the follow-up period. 4 were transplanted, 4 are waiting for transplant, and 2 developed hepatocellular carcinoma. One of them died, one of them is still alive, waiting for transplant. Now, why is it a problem to transplant people with fatty liver? First, they have cardiovascular contraindication or renal contraindication. They are not good material for transplant. And one of the biggest obstacles is their relatives are obese. So donors from living related is a big obstacle. And when the relatives cannot donate, what do? You seek cadaveric transplant, which is not easily accessible. We don't have a program of cadaveric transplant in Bahrain. We refer them to Saudi Arabia. They are not priority list there. And most centers now demand a living related donor. Like the center we deal with in Chennai demands a living related donor. I went to the extent of putting 2 people of relatives on diet, and one of them underwent bariatric surgery. Actually, 2 underwent bariatric surgery to make a liver available from relatives. Okay, so it is a big obstacle. By the time that relative loses weight, this patient is too decompensated to undergo the surgery. What happened to the people who followed the diet, who actually were compliant to the diet? Okay. Now, compliance is of variable degree. Some people are very serious. They take it very seriously. They go strictly on diet. They exercise and they are convinced. Okay. And majority of these people are not Bahrainis. I will say that. Unfortunately, they are not the Bahrainis. They succumb here to eating dates again and rice again and bread and so on. So those who lost a very significant amount of weight, more than 15 kilo, those who lost between 10 to 15, the majority lost between 10 to 5 kilos in weight. But those who did not follow, at the end of 1 year, gained 3 kilos. In decompensated cases, a similar trend, but they are hard to deal with diet. These people, many of them have either renal disease or liver disease, they cannot follow a low-carb diet, basically. So we have to modify their diet to reduce the protein intake in their diet because they go encephalopathic or they develop elevated creatinine. You have to modify their diet, and if I see the trend of creatinine going up or they develop encephalopathy, I have to stop them. What happened to their shear weight? Those who lost weight and were compliant to diet had a dramatic drop in their shear wave, indicating fibrosis is reversible. Actually, I have one of my patients who had a liver biopsy. She had cirrhotic nodules. She's a young lady, 32 years of age, diabetic for at least 15 years before I saw her, morbidly obese. She underwent bariatric surgery. We had a biopsy of liver showing F2 cirrhosis, F2 fibrosis, and she reversed to completely normal after bariatric surgery. She regained the weight and regained back her high shear weight. So you can tell the patient very truthfully that if you reverse obesity, you can reverse this fibrosis. And it is true, proven scientifically, not only with us, but proven with many centers in the world that this disease responds to the metabolic correction of their disorder. In decompensated, a similar trend, but in the non-compliant, of course, we didn't move much, but they don't go back to normal shear wave or near normal shear wave because fibrosis is already established. Now, what is the best modality to make them lose weight? I still think bariatric surgery is the best for those who accept it and who can go for bariatric surgery. And I highly recommend it to my patients. The average weight loss with bariatric surgery in our group was about 29 kilos. The average weight loss with diet alone was about 7.9 kilos in 1 year. And with addition of Ozempic, it's about 13 kilos, 12 to 13 kilos. Now, why is it that some people store fat, but they don't kill their liver and others do? It is a puzzling question, and if we solve that issue, I think we will know how to treat Nash. First of all, some people store fat and remain with fatty liver all their life, and they never progress to cirrhosis. They may die with other events like cardiovascular or stroke, yes, hypertension, and so on, but they don't develop Nash cirrhosis. Why is it that they don't? The question is, what mechanism triggers liver fibrosis in some people with the same fat deposition, and some people don't react by fibrosis? There are multiple theories, but there are several mechanisms here I want to list of what happens when triglycerides are stored in the liver. First of all, some people have very high triglycerides and yet it does not store in their liver much as others. Second, lipotoxicity is highly variable depending on multiple mechanisms, like how bad is their insulin resistance, how bad is their immune reaction to the fat. Some people just ignore it and they don't react to it, and therefore they don't go into the inflammatory phase. How active is their fibroblast in attacking this fat area and causing deposition of fiber is again highly variable from one patient to the other. So drug companies, because they see this epidemic of NASH and fatty liver, are working on several of these mechanisms, okay? And several randomized trials are now involved in management of thyroid receptors. I will talk about this. Thyroid receptors are very important in fat deposition in the liver. They are major modulators of how much fat is deposited and what happened to it. GLP agonists, we all know about it, GIP agonists. There are several other inhibitors of fat deposition, which the drug companies are working on. They're also working on how to settle this stellate cell, which deposits fibroblasts. So I will just mention what drugs are available so far. Vitamin E is known to reduce fat deposition in the liver. However, when you give vitamin E, you should think of the side effects. Synthetic vitamin E is associated with higher stroke rate, hemorrhagic stroke rate, and also with prostate cancer in the long run. So I don't usually advise vitamin E in high doses to my patients, except in a small subgroup who have no risk of prostate cancer, like females or those who don't have hypertension or cardiovascular disease. If they have coronary disease or cardiovascular disease, I stay away from vitamin E. The glitazones used in diabetes are effective in reducing fat. They have never been proven to reduce rate of Nash. They do reduce fat fraction in the liver, and they do regulate sugar when you look at sugar control. However, they cause weight gain on average about 3 kilos. They are associated with bone fractures, and if the patient is not diabetic, the patients usually will develop hypoglycemia. So you can use it in the diabetic patient, but you have to be aware of the risk here. 2016, there was popularity of this drug, opticolic acid. It's a bile acid. It binds to the ricinoid X receptor, and it regulates multiple processes in liver, such as inflammation, fibrosis, metabolism of bile acid and glucose. However, unfortunately, in a phase 3 reverse trial, it was conducted on patients with Nash, with compensated Nash, not fully cirrhotic, and it did not meet the endpoint of reversing fibrosis. When the slides were compared pre and post treatment, after 18 months, there was no benefit of this drug in reducing the rate of cirrhosis, so the FDA said stop the study. The company making this drug is challenging the FDA rejection and is asking for a review of data using artificial intelligence in reading slides. They said the pathologist gave a biased idea that there is no improvement. We want to read these slides by artificial intelligence and reanalyze the data. And they're still arguing with the FDA whether it will be allowed. Now, GLP agonists, they are very popular. There is a shortage in the world of this drug because of popularity for weight loss. And phase 3 clinical trials are underway. So there were several studies done, but the largest study expected to be released is a 1,200 patient study of Nash to assess effectiveness of 2.4 milligram once weekly subcutaneous injection of semaglutide. The expected date of completion of analysis of the data is still way away in 2028. So we don't have the answer. Does it reverse Nash? We know that it is effective in weight loss. We also know that it reduces fat fraction in the liver. We don't have the final answer. We're waiting. Similar study is being done for Monjero, which is a GLP-GIP agonist. There is a new drug which has been published in September 2023. This drug is a long-acting glycolylated pegylated fibroblast growth factor analog. It's developed by the company to prevent Nash or treat Nash and also treat hypertriglyceridemia. 219 patients in stage F2 and F3 fibrosis received once weekly injection, 15 milligram versus placebo, and after 24 weeks, they compared the fibrosis score of these patients before and after therapy. Common side effects were nausea and diarrhea. It showed effectiveness in phase 2 trials. We're still waiting for phase 3 trials, which have been started. The most exciting drug, which soon will be approved for treatment of Nash, is actually a selective thyroid hormone receptor. It's called resmetirom. It's an agonist of T2. Now, many people among us know T3, T4, but what is T2? I just heard that there is a T2 receptor on the liver, and this is what regulates triglyceride entry into the liver, as well as what happens to it once it enters the liver. So people have used this drug in phase 2 clinical trials as well as phase 3. And what this drug does, it prevents triglyceride accumulation in the liver as well as accelerates apoptosis of liver cells containing triglycerides. There were 2 studies done, one of them using non-invasive method of selection of patient and follow-up, use of MRI fat fraction, and it demonstrated that after 12 and 36 weeks of therapy, the fat reduction was 30% in those who received the active drug versus 4% in those who received placebo. And in this trial, again, diarrhea was experienced by about 20% of patients, but it definitely affected lipid profile, dropping the triglycerides and reducing the incidence, hopefully, of cardiovascular events. Definitely the triglyceride level corrected. There is a huge study of 1,200 patients. This is randomizing patients in 4 categories, one of them receiving 80 milligram of this drug. It's received orally once a day as a tablet. The other one receiving 100 milligram. The third group is receiving a placebo, and one group is open label receiving 100 milligrams. So they know this patient is actually receiving 100 milligram. The investigator is not blinded to this last group. They know they are on active drug. And what they selected as patient is either a patient has had a liver biopsy or by non-invasive techniques. So they are a mixed bag of selected patients. Some of them had a liver biopsy, some of them never had a liver biopsy, but they have fibrosis score which is high by non-invasive methods. Primary safety point and several key secondary points were met, including LDL reduction, apolipoprotein B, reduction, triglyceride lowering, and reduction of fat in the liver determined by MRI fat fraction. Reduction in liver enzymes was also achieved, fibroscan improvement, MRE scores, and other Nash biomarkers were positively affected. There is now the most important and exciting study is this study done on Nash. It's a multi-center randomized double-blind study, phase 3 on the same drug, liver biopsy confirmed Nash before and after therapy with this drug. The study enrolled 1,000 patients so far and biopsy-proven Nash stage, most of them in stage F3 and F2, so advanced fibrosis, and small amount of patients in F1. And they were randomized to receive once daily 80, 100 milligram or a placebo of this drug. After 52 weeks, a second liver biopsy was done. So every patient who entered the study agreed to a liver biopsy before and after the drug. So primary surrogate endpoints on biopsy of Nash resolution of 2 points, reduction in NAFLD activity score, and with no worsening of fibrosis was the criteria for success of therapy. Achievement of either primary endpoints was considered successful outcome, as well as secondary endpoint of lowering of LDL. It was effective. It showed that after 52 weeks, there was reversal of some fibrosis, as well as improvement in NAFLD activity score. So because of this very, very important study, the FDA agreed to give a priority review date to approve this drug. And this is expected to be released in March of 2024 if the FDA gives the final approval. Now, what is beautiful about this drug is this drug has a good safety profile, and among these 1,000 patients, only 20% developed transient diarrhea for the first 2 weeks, and then the diarrhea subsided. There were no major side effects as severe itching, which is seen with bile acid therapy. There was no liver failure related to the drug, and there was no major increase in other events like death or hepatic encephalopathy. So, my conclusion is that these drugs are going to be very, very instrumental in treatment of Nash if they become available. How expensive they are, I don't know how expensive, but they are reported to be quite expensive. In conclusion, NASH is evolving as the most common liver disease in our area and all over the world, and the most common indication now for liver transplant. Weight loss so far is the only proven modality of cure or reversing the condition. I urge people to detect these patients at early stage where the reversibility is possible. Doctors in primary care should be the first screening guards against this disease by just estimating abdominal girth and looking at BMI of patients and measuring their sugar and looking at their lipid profile. And they should recommend weight reduction therapy. And they should have a structure for doing this weight reduction therapy by a dietitian, offer access, offer reading material, and maybe exercise classes. 2/3 of diabetic patients attending healthcare centers in Bahrain have fatty liver. Imagine if about 3 to 10% of these people will end up with cirrhosis. The load of cirrhosis and liver transplant, just give it 10 years, and what will happen? There will be a huge budget allocated to just dealing with these people. Abdominal ultrasound is a very useful bedside method of detecting it. We do abdominal ultrasound for all sorts of reasons. When we detect fatty liver, the patient unfortunately is not even alerted you have fatty liver. They just write it in the report. Clinician says, you don't have gallbladder disease, go away. They don't treat their fatty liver. Weight reduction by diet alone can reverse, and definitely we have proven it can reverse. However, compliance of patients is a major issue. When diet alone fails, we should not stop. We should offer them drug therapy like GLP agonist or refer them to bariatric surgery. We should not give up with these patients. Obesity is a real disease. We should not give up on it. Many new drugs are under evaluation for NASH, but unfortunately, nothing so far has been approved. I am very hopeful for the last drug, which is the thyroid receptor agonist, to be a useful drug. GLP, GIP agonists are useful, but we don't have data on NASH. We definitely have beautiful data on cardiovascular risk. Yes, it can decrease cardiovascular events, and New England Journal publication on this is very clear, and therefore anybody who's diabetic with severe fatty liver, you treat with this drug in the hope of reversing their early death from cardiovascular event, and hopefully it will show also effective for NASH. And that's it. That's all I have to say about it so far. Thank you.